Thank you, Alex. That was lovely. Okay. Here we go. I have read a little bit about what you're trying to do here, and I think it's really impressive. So if I stand over here, can you still hear me? Okay. So I wanted to tell you a little bit about the history that I'm aware of that makes what you're doing so wise. So I wanted to talk about two strands in history. One, the transition that we made in the West from an emphasis on fundamental research to a concept called use-inspired research. And then I want to talk about the transition from what we used to joke about as eminence-based medicine. You had to have a lot of gray hair to practice it, to evidence-based practice, meaning that you were doing something that had a basis in science. To talk a little bit about how we've implemented this in an interdisciplinary way involving multiple disciplines. Sometimes people think that evidence-based practice is just a metaphor, but it really is not. There are, particularly if you're going to be using this as the center's name, it's important, I think, that you understand the core concepts of the evidence hierarchy, the 3 circles model, the 5 steps, and the importance of systematic reviews and guidelines. So I'll talk about that. Okay. So what do I mean when I mention the transition from fundamental research to use-inspired research? There's a historic figure called Vannevar Bush, who was a top science advisor to the president in the United States. He was a very brilliant man, an electrical engineer. He was chief science officer during World War II and was the chief science officer to Franklin Delano Roosevelt. He was responsible for founding the National Science Foundation in the U.S. So in the U.S., our 2 big funding agencies are the National Institute of Mental Health, which funds research on health problems and diseases, and the National Science Foundation, which deals with everything else, basically with basic science that doesn't have a direct practical application to health. And Bush was known for he had a very strong bias that applied research drives out pure research. That it was, that you really had to preserve the ability of scientists to be able to play and to discover whatever it was. You didn't have that, it was important not to tie it down to being useful. And he felt that this research pipeline was the way things worked. That you started out with basic research. This is where the breakthrough ideas came from. Then you develop a way to apply those ideas. Then you develop sort of an assembly line to production and operations. So you had a very linear model. It always flows that way. This happened to be at the same time that a physical chemist and novelist in the United Kingdom named C.P. Snow wrote a very influential book called The 2 Cultures and the Scientific Revolution. And what he was talking about was there are 2 traditions that existed at the time in the intellectual community, in both the U.S. and in Britain. One community was the humanities, the scholars of Greek and Latin and the arts, and literature, and the other was the scientists. And they were very, very much divided. They didn't understand each other's methods. And there was also an aspect of, was like Thorstein Veblen's The Theory of the Leisure Class. Each group prided itself on being somewhat unnecessary. It was like a leisure time activity. They didn't have to have any practical use. And so, you can understand that about Greek and Latin. Nobody needs to use it as a modern language. But for the sciences, that same sort of value system applied. And this comment is one that he made, and it actually applies very much to how I was trained in graduate school. we prided ourselves that the science we were doing could not in any way have any practical use. And the more we could make that claim, the more superior we felt. So this is a very strong commitment to basic science that's for its own sake. It shouldn't be useful to anybody. And so this is how many of us were trained. Well, it's taken us a while to get over this divide, and I think it was a very unfortunate divide. This book, Donald Stokes' book, Pasteur's Quadrant, was a very important way of understanding this a little bit better in a more balanced way. So what Pasteur did is to say, look, there's two traditions. One of them is your basic science tradition over here on the left, where the driver, the motivation for doing the work is a quest for fundamental understanding, to understand how things work. There's another motivation for doing research, and that is because you're trying to find something useful. You're trying to solve a practical problem. And what we had been doing was forcing things into basic or applied. Pasteur said, look, there's really a fourfold table here. There are quadrants. So if you take somebody like Niels Bohr, he was really doing just basic research for the sake of understanding the structure of the atom. He's no consideration of application, just trying to understand that. On the other hand, you take somebody like Thomas Edison, who invented the light bulb, very important, but all he was trying to do was to invent a light bulb so he could sell lots of them and make lots of money. That's pure applied science. But then you have somebody like Pasteur, the French microbiologist. Pasteur probably had more of a valuable scientific contribution than either of the other two, but he was trying to solve a practical problem. What he was trying to do was actually not the problem he wound up solving, although he solved this problem as well. He was trying to help the French farmers who were trying to make alcohol from beets. And they had a problem. Sometimes the fermentation would be off and the wine would be sour. It wouldn't taste good. So this led Pasteur to study what was going on when the fermentation process went awry. And in the course of this, he discovered various microorganisms that could contaminate the wine, some of which could live without oxygen, and went on to dispute the theory of spontaneous generation, that animate objects grew out of nothing. He formulated germ theory, went on to develop vaccines, pasteurization, and made many, many important scientific contributions. But these were coming out of trying to solve a practical problem. He just kept his mind open and made basic science discoveries along the way. So I think this is just a really useful way of thinking about things. It's not either or. You really can do both. And it's sort of a silly, not very productive distinction when we force things into one or the other. So we have become more practical about trying to solve real problems through science. And you can see, for example, this our former president, President Obama, who wanted us to tackle the fact that in the U.S. we have by far the most costly health insurance, and yet our life expectancy is only 25th. So something is really wrong here, and Obama wanted to apply science to solve this problem. At a more global level, these concepts are very much part of what the World Health is doing, where they are bringing all of the disciplines to bear in complex system approaches to implement health in all policies. So the notion is here that, when we think about health, we first think about the doctors and the nurses and the folks who are in the discipline of dealing with making people better. But in fact, a lot of the influences that have even more potent influence on our health come from education, come from the financial sector. So things like zoning, food advertising, transportation, parks, workplaces, restaurants, taxation, all of these things have implications for health as well. So we need to think about how they're connected and be thinking about the downstream consequences every time we make a policy change. So this is originated first with health in all policies, but I would not be surprised to see that we're going to see economics in all policies, education in all policies, because these are really quite connected. Okay, so now let me shift to talking particularly about evidence-based practice and the history of this in medicine and health. So something that it's easy for us to forget is that up through the 1800s, there really was not any very good basis to have evidence-based almost anything, but certainly not evidence-based medicine, because we didn't know an awful lot about what worked. We hoped that things worked, but it was sort of guesswork. It wasn't until the 1800s that we learned that if you did surgeries under antiseptic conditions, people lived longer. That if you used public sanitation, people didn't die so much of things like cholera and typhoid. So these were some of the first real successes we had in bringing science to bear on problems of health. So before that, people sold snake oil and all kinds of things in bottles, claiming that they did good work, and there was no way to prove that this was wrong. There was also no way to prove that it was right. But finally, we began to have some evidence of policies and treatments that actually worked. So there was a need to change the educational system for how doctors were trained. Up until the 20th century, the way that doctors were trained was in proprietary medical schools. These were very much like barber schools, where people go to learn how to cut hair. You didn't have to have a college degree to go to medical school. You just had to be able to pay the fee. And the way that they worked were that physicians got together and taught the students who could pay. And they offered lecture courses, and they divided the money among themselves, so it was fairly inexpensive. But they didn't do certain things like, they didn't teach them any science. There were no lab courses. There were no dissecting cadavers. It was, sort of like the lecture in your professor's living room, and that's what it was. Well, finally, once we began to have some evidence that some things worked, really, and some things didn't, there was a press to clean up medical education. And this person, Abraham Flexner, who's an educator, was commissioned by the Carnegie Foundation in the U.S. to do this. So he went and he studied in German medical schools for a while to see what they were doing, and he came home and he really shook things up. At the time, in 1910, there were 155 medical schools. He felt that only 31 of them should still be standing. So he really tried to close most of them. By 1930, he had actually succeeded in closing half of them. So the Flexner report, is seen as the first triumph of evidence-based medicine. It was a real cleanup operation. Now the schools, people had to have some training, they had to have a college degree, science had to be taught, there had to be laboratory courses, and there had to be real hands-on clinical training. So this was a big shakeup. In some ways, I think that we in psychology are still living out this issue, and we live it out in a way that is more like C.P. Snow's old way. We are still trying to figure out whether we are doing science for science's sake, or whether we are doing science for some use. And I personally have lived through some of this. I went to Harvard starting in 1971. This happened to be the year that Harvard eliminated its clinical psychology training program. Stanford had done the same thing a few years ago because they felt that all this trying to help people got in the way of doing pure science. And so once again, we said, no, you can't do really good science if you're trying to have application. And to some extent, what we have just lived through with the Academy of Psychological Clinical Science coming in with a whole new science-based accreditation policy revisits this. I think it's an unfortunate way of acting out the question of, okay, what is helping people? Is it an art with no science base, or is it a science? I think it has to be a bit of both, but we're not quite as far along with this as I think medicine is. Okay, so how did medicine make this history? So there are several important benchmarks that I think are worth knowing, and one of them is a very important charismatic person named Archibald Cochrane. Everybody calls him Archie Cochrane. Have you ever heard of the Cochrane Collaboration? Can I see hands if you've ever heard of this? Okay. Okay. So Cochrane, was a British physician who is a very interesting character. He became interested in psychoanalysis, and he went and was analyzed by Theodor Reich, who was a student of Freud, for a sexual problem. The treatment didn't work, so he was turned off on psychoanalysis, but he learned German, which was very good because he got stuck in a prisoner of war camp. And he wound up being the top, the physician in charge of all the prisoners of war. And everybody was terribly sick and malnourished and so forth. And he had the opportunity to do his first randomized controlled trial. He thought these folks looked like they had beriberi, and so he treated one group of them with yeast and another group with vitamin C. The group with yeast got better, and he thought, this is a way of really finding out if things work. So this was his first exposure to a randomized controlled trial. He came back at the end of the war to Great Britain, and now he got into a program in epidemiology where they train physicians on research methods, including the randomized control trial. So he learned that what he had invented on his own actually was a technique for doing research to find out what works. He also was now exposed to the real impoverishment of much of the population of London after the war. And he wound up trying to solve social problems. He became very concerned that there are all these people that need care, they're very sick, but they want more care than the government can afford. So how do we deal with this? And he came to the conclusion, he wrote this wonderful book called Effectiveness and Efficiency, Random Reflections on Health Services. Random is a play on words on randomized control trial. And basically his argument was, look, because healthcare resources are always going to be not enough, what we have to do is to figure out what works and what doesn't, and only pay for what works. In his honor, the Cochrane Collaboration was established, and I'll talk to you a little bit about what this is. It's a very important cornerstone of evidence-based practice. Okay, so at the same time as Cochrane was playing with these ideas that in many ways were behind the formation of the National Health Service in the United Kingdom, a fellow named John Wenberg from Dartmouth was looking at how people were treated in different parts of the U.S. for different conditions. And what he observed was that there was a vast variation in how people were treated. If you were in Kalamazoo, Michigan, and you had a heart attack, you were likely to get one kind of treatment. If you were in Boston, you were likely to get another. If you were in Dallas, you were likely to get another. And the costs varied all over the place. And did you always get a better outcome if the costs were higher? No, 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 no. In fact, often not. But what was clear was if you happened to be in a place that had an academic medical center, they were going to do more stuff to you, and it was going to cost more. But your outcomes weren't necessarily better. So this was sort of a very rude awakening. Okay, so that happened, and people were on both sides of the Atlantic were puzzling about this. The other was we began to become aware that research was not being translated into practice to the degree that it should be. So the Institute of Medicine in the U.S. observed that only 15% of clinical practices were based on any evidence. So 85% were based on what people's colleagues said they were doing, what they had learned in medical school, what somebody had always done, but there was no evidence. They were like old wives' tales, like fairy tales, but people kept perpetuating them. The other thing that became clear is that the uptake of scientific discoveries into clinical practice was terrible, that only 14% of scientific findings are translated into practice after an average of 17 years. So, all this research that the government pays for, nobody's using it. Okay, then the last piece here is that in Canada, at McMaster University, there was a bunch of people, started by David Sackett and then Gordon Guyette, Brian Haynes, Ann McKibben. They were trying to figure out how to use research in the clinical practice of medicine. And they were really sort of wild. So you see up here one of the devices that Sackett was using. This was before the internet. But what he wanted to do was, docs, when they were trying to treat patients, sometimes questions come up that they don't know the answer to. And he wanted them to be able to go to the library. But the library at that time was, across the campus, and it was all books and so forth. So he had CD-ROMs on a computer, and he had a librarian traveling around with the docs while they made ward rounds, and they would look up stuff that they didn't know the answer to. So this sort of bringing the evidence to the bedside is very much what the McMaster folks were about, and we'll talk a little bit about how they really were sort of the immediate on-the-ground engines behind evidence-based medicine. Psychology was in there at about the same time. You may have heard of empirically supported treatments. This was a way that in the United States we tried to make sure that clinical psychologists were practicing something that had an evidence base. Steve Holland and Diane Chambliss were behind this. They said, look, okay, we'll say something has an evidence base if there were 2 randomized controlled trials that support it or a series of case studies. They just sort of picked that number. But it was, it was a step in the right direction. It was a decent idea. Okay. So this is the first definition that the McMaster group came up with. They didn't use the term evidence-based medicine. They used the term scientific medicine, and this was their definition, that it's the conscientious, explicit, judicious use of current best evidence in making decisions about the care of individual patients. So that sounds pretty good. People hated it. Why did they hate it? The docs hated it. They felt it disrespected them. It didn't respect their expertise. It diminished them. And as high-level scientists, as this person, Bernadine Healy, who was the head of the National Institutes of Health at one point, wrote this article saying that the autonomy and authority of the doctor and the variation, that this is what evidence-based medicine is trying to do away with. So this was a problem. If you don't have the head of NIH supporting evidence-based medicine, this is going to be trouble. So what they did, whoa, I think I skipped something. Oh, okay. So but the docs sort of, they felt it was time to clean up the act. So they wrote some very funny editorials. This is one in the British Medical Journal saying, okay, here are your 7 alternatives to evidence-based medicine. If you're doing evidence-based medicine, your randomized controlled trial is what you're basing your decision on. If you're doing eminence-based medicine, it's the radiance of the white hair of the person who's treating you, the distinguished authority. Or vehemence, how aggressive the person is in perpetrating a particular practice, or how eloquent, or how convincing. So they wrote sort of sarcastically saying, look, we need a sound basis for practice. Okay. So, I think what we see here is that people were responding, clinicians were responding, that evidence-based practice was disrespecting them, was constraining them. And I think we still struggle some with this in psychology. These are comments that came from the American Psychological, the Academy of Psychological Clinical Science, in response to some of the evidence-based practice movement. They say, look, clinicians are just sort of naughty. They want to do whatever they please, and they don't want to pay attention to the scientific research. And I don't think that's the case. I think it's just challenging and hard, and we want to stay out of these sort of either-or arguments that the fields can get into. Okay, so let me now come to some of the core concepts of evidence-based practice. Evidence-based practice always involves a 3 circles model. Now, what's been in those 3 circles has shifted over time, but here's the gist. So this is the first model that came from Sackett and Haynes, and in many ways it's the best known. So what's involved is you've got the best available research evidence, you have clinician expertise, and then you have the patient. Their values and preferences need to be taken into account. And when the 3 things intersect, you have evidence-based medicine. So just to read it, it's no longer scientific medicine, which was only about the research. Now you see the more inclusive definition. It's the integration of clinical expertise, notice that's first, for political reasons really, patient values, and the best research evidence are integrated into the decision-making. Clinical expertise refers to the clinician's cumulative experience, education, and clinical skills, giving respect where it's due. The patient brings to the encounter his or her own personal and unique concerns, expectations, and values, and the best evidence is usually found in clinically relevant research that's been conducted using a sound methodology. Okay, sounds pretty good. Okay, they revised this model a few years later, and this was the next version. It still has research evidence and patient preferences and actions, but what they did was to move the clinical expertise more centrally, because basically the challenge of the clinician is to try to understand what's going on with the patient. So you have to deal with their state and their whatever problem they bring, and you need to try to weave in these other elements. So that seems sort of reasonable. This is the model that an interdisciplinary group of us, funded by the National Institutes of Health, has developed. It's a transdisciplinary model of evidence-based practice, and part of what drove us to do this is it applies not only to medical treatment, which tends to be drug, device, or pill-based, but this also applies to interventions that are psychosocial or behavioral or cognitive, which are a little bit different. So I'll show you in a minute which disciplines came together for this, but it's similar. We still have the best available research evidence. We have, instead of clinical expertise, we have a decision-making process in the center, because that's what you have to do to make care decisions. And we have the clients, not just their preferences and values, but also their characteristics. And a big important factor as we move towards more population-wide healthcare, we have a lot of concerns about resources. And particularly when it comes to psychological or behavioral treatments, one of the resources is also the clinician's expertise. Like, for example, are you trained to do dialectical behavioral therapy? It might be the best treatment for a patient with borderline personality, but if you've not been trained to do it, I wouldn't advise it. So these resource considerations enter in pretty prominently. Okay, so here is how we went about developing that model. And it was really quite a wonderful experience. We brought together, so I'm a psychologist, Ross Brownson is a public health expert, Ed Mullen is a social worker, Robin Newhouse is a nurse, an opinion leader, Jason Satterfield is a psychologist who trains physicians, and Steve Purcell is a physician. And we had a very distinguished advisory board, including some people like David Barlow, Gordon Guyett, who actually is the person who coined the term evidence-based practice. We also had, and this was an education to me, we had practitioners of two stripes. One kind dealt with individual patients, and another type was social workers and public health experts who deal more with communities. They're dealing with populations. And so to develop some of the materials we developed, we wanted folks that were immersed in that world. So we would be not sort of talking from the ivory tower. Okay. So what you can see here is that evidence-based practice has spread through all of the different health professions. This is the original book, was at first by Guyett, now not even on there any longer. Evidence-based medicine, this pocket book that they keep in their white coats. Evidence-based nursing came out soon after this. Evidence-based public health, this is Ross Brownson's book. Social work was right in there early. Leonard Gibbs has this wonderful book. Another one in social work by Alan Rubin. And then psychology was late coming back to this table. This is by Norcross, but eventually American Psychological Association adopted this view. And here are a couple of additional new ones. Okay, so what's all the fuss about? Why? What's the advantage of evidence-based practice? I think it's really these four things, and they are pretty darn important. For one, we need to have very good quality to the care that we're providing, and we need to be accountable to patients that we're not giving them snake oil, that we're giving them things that really have an evidence base that they work. And we need this evidence base to influence coverage policy. We don't want treatment to be paid for nonsense and not to be paid for things that work and are needed. The other thing that's happening, and I'm curious actually how much it's happening here, it certainly is happening in the United States, is we are moving more towards practicing in terms of integrated care because there's so much problem with care silos and trying to communicate across them. So now it's common to have health professionals from many disciplines on the same team. And the fact that everybody is being trained in the same model gives a basis for communication. It's sort of like you were socialized in a similar way. Another important thing, and this will go to the Cochrane Collaboration, to systematic reviews and guidelines, is you really need an infrastructure to be able to practice evidence-based medicine. And you need some way to get the evidence pulled together for you and parsed and appraised, because it's a lot to do yourself. And ideally, the infrastructure that pulls together what we know and where the gaps in our knowledge are should be driving the National Institutes of Health and NSF to say, aha, these are the problems we don't know the answers to. Fund somebody to figure out the answers to them. So this is how things would work in a sensible system. Okay, so why do I say we need an infrastructure? When we talk about barriers between research and practice, this one is huge. There are literally 2.5 million scientific papers published per year. Has one of you read all of them? Literally 28,000 peer-reviewed journals in print, 7,000 articles published every day. It's completely overwhelming. How could anybody keep up with this evidence base? So we need help. We need an organized system to help us tackle this. And these are some of the systems. So we talk about the primary research literature, which you can find in your research databases. So if you're a psychologist, you tend to go to PsycInfo, or Medline or PubMed. CINAHL is the one for nurses. Do you folks use Embase? No? Okay, Embase is usually the one for us, it's international articles. It's also more expensive for us than the other one, so sometimes we don't get it. The Cochrane Collaboration, which I mentioned before, critical cornerstone of evidence-based practice. This is an international organization all over the world where people come together to do systematic reviews, consolidating the evidence to figure out what works. And I'll show you some examples. They do this for healthcare interventions, for interventions dealing with individuals. There's a parallel one called the Campbell Collaboration, which does this for social interventions, education, crime and justice, social welfare. And then there's another body called the Center for Reviews and Dissemination, which is at York. It does a lot of systematic reviews as well. They have about 160 of them up there now. Oh, and I want to flag for you, notice the logo for the Cochrane Collaboration. Remember that. I'll come back to that and tell you what it means in a bit. Okay. So systematic reviews, the Cochrane Collaboration really drove them, but they've become increasingly important as a basis for healthcare policy and reimbursement. So a lot of concerns about trying to standardize them, make sure that they're really good. The Institute of Medicine did a book in 2011 called Finding What Works in Healthcare that is about systematic reviews. So what's a systematic review? It's an investigation that focuses on a specific question, uses explicit, pre-specified scientific methods to identify, select, assess, and summarize the findings of similar but separate studies. So this is how we make the body of evidence cumulative. This is how we keep learning, and we pull together what we've learned from separate studies. Okay. So what does that look like? Well, here are some of the things that they now require, that they say should be characteristic of a systematic review. First, the team has to know what they're doing. They have to have some expertise. The conflict of interest rules have become really, really important. You want people pulling the evidence together who are neutral, who don't have a financial stake, they don't own stock in whatever the intervention is. They're not marketing the intervention and standing personally to gain. You also want stakeholders involved. You want the patients who have whatever the condition is involved. But you have to do this in a way that keeps the independence of the scientific review group. You want the perspective because you want to understand, but you also want the scientists to be able to do their work. You formulate your questions and you publish your protocol. It's got to be structured and pre-stated. You say what your search criteria are, what your inclusion and exclusion criteria are, how you're going to pull the data, what variables you're going to pull, and then you specify your criteria for critical appraisal. I'll go through all what is. You probably need a librarian to help you search. There's a second page of requirements. Mostly what you're doing when you're doing a systematic review is you are evaluating threats to the validity of the finding. It's called bias. What are some of the main biases? Biases in the reporting of the results. I mentioned that many of us in the U.S. can't afford Embase, so sometimes we don't pull articles that are cited in Embase because we can't get it. So we leave out a lot of the international literature. The gray literature, how about things that are published in conference reports and they never made it into a peer-reviewed journal? How about things that were reported in a registry of randomized controlled trials, but they never got published? A big one, how about if you're not summarizing the studies that were not in English? This turns out to have a big impact. What about the file drawer effect, that we know that studies that have negative results are less likely to be published? There are actually analyses, funnel plot analyses, that can tell you the likelihood that you've missed some that are negative results. And then there are just sort of procedural perfectionist things. Double extraction, having one person do it and then somebody else check it. All of these kinds of things, often there will be a quantitative synthesis of the results in a meta-analysis. Not necessarily, but that's a decision that has to be made. Okay, so here is the results of a systematic review, so you can see what this stuff looks like. So this happens to have been one evaluates from the Cochrane database. It's evaluating cognitive behavioral therapy, third wave cognitive behavioral therapy with more Asian infusion, and interpersonal therapy-based interventions to prevent depression in kids and adolescents. These are some of the studies. So there's quite a number of them. And what you'll see is that what they're doing, they are comparing the intervention and the control, the no intervention group, and they're comparing the number of events, the number of depression events that occurred in the group that got the intervention versus the group that didn't, compared to the number of people that were in each arm. And there's the difference is being reflected here and plotted here. This line in the middle is the line of no difference. So if the results of a study cross that line, the findings are not significant. And so what you see, as you see in most meta-analyses, there's a mix, there's variation of the results. But the overall is a small benefit in favor of this intervention. So now let's go back to where did this logo come from Cochrane? That is the logo for a classic study of using corticosteroids to give to moms who were about to give birth to premature babies. There had been a lot of evidence, but much of it inconsistent, suggesting that there was some benefit to the life of the newborn if moms took corticosteroids right before they gave birth. And but you see that the results were a little bit inconsistent, but this demonstrated a net benefit, and so it changed the practice of OB-GYNs. So this is why they do this. Now, what is all of this over here? This is the quality ratings. This is when we talk about critical appraisal, this is what's going on. For every one of these studies, somebody is rating all of these parameters that gauge how good a study it was. Things like, were the people randomly assigned to the groups? Was the allocation concealed? Could I tell when the person came into my office, did I have the ability to influence whether they were going to go into this group or that group? Could I cheat, basically? That's allocation concealment. Were the people who assessed the outcome blind to what treatment the person had been in? Because otherwise they can bias if they believe in the intervention. Were the interventionists biased? Or were they blind to what the comparative treatments were? Was there a lot of missing data? And so every one of these things gets a rating. You can see they're color-coded here. And that rating influences the weight that's given to the finding from that study. So this is what a systematic review does. It summarizes the evidence, weighted by the quality of the evidence, and that's the result. Okay, you're not done when you have a systematic review. As an individual clinician, you could be done just fine. This is telling you what you need to know. But from the standpoint of what should payers pay for, there's a next step. which involves translating the systematic review into a clinical practice guideline. And the Institute of Medicine also came up with a set of policies about this and what it takes. And basically here you are translating the evidence into a how should you treat people policy. So you want to look at the benefits and the potential harms of each care option. Okay. Lots of standards here as well. Again, you want transparency about who paid for this. You want to know if there's bias in the people doing the review. It's got to be transparent. You want a multidisciplinary panel because you don't want just one health profession. You want all the health professions that are going to be working together. You want it based on a systematic review. It's got to summarize harms, and this is something that's been very challenging for us as psychologists to learn. I think we've always said, look, medical interventions can hurt people, but we're not going to hurt people. Sometimes we do. Critical incident debriefing was an example of sometimes we do. So we have to push ourselves to evaluate harms. You need a mechanism for external review, and this one is really important. You need a mechanism for revising the guideline. This is where most guidelines fail because it costs a lot of money to do a systematic review. You do it, the guideline is written on, but then the literature continues to proliferate and nobody updates the guideline. Nobody updates the systematic review, nobody updates the guideline. We don't know whether the practice recommendation should have changed. This may sound a little bit silly, but something we know in pharmacology is there's a saying that is use the new drugs while they still work, because the efficacy of treatments tends to drop over time. So this is a very important problem. So the Institute of Medicine flagged it. So where do you find guidelines? Well, you can find them in, this is a resource called www.guidelines.gov. More than 1,000 guidelines are in this, international guidelines as well as US ones. Here's the AHRQ one for prevention guidelines, also another huge database. Here's the one from the UK, from the NICE guidelines, National Institute of Clinical Excellence. I particularly like those because they are so efficient. This is a one-page guideline that you can pull up on the web for treating bulimia. It tells you what to start with, what to try next, how long to do it, and they managed to get it all in just a page. It's really nice. And here's another important resource. It has a great nickname. It's GIN. It's the Guidelines International Network, and they have a lot of guidelines. It's another international body. Okay, some cutting edge just stuff to know about, things that are coming down the pike. You can tell, so basically what most guidelines do is they tell you this is the best treatment, or for psychosocial treatments, the best treatment package to use for the average person. But who among you treats an average person? So we know that there's variation. So where the future is moving in guidelines is to what's called operationalized guidelines that tell you things like, where do you start? What do you do if that doesn't work? So basically the guidelines take the form of an algorithm. In some of the really complex forms of these that use machine learning from the computer sciences, you are actually evolving slightly different dynamic guidelines as you learn more about that person's response. These will wind up being things that are programmed into the electronic health record. This is where the future is going. Okay, resource-sensitive guidelines, particularly because some of these things will be rolled out in very poor countries. Some make different recommendations. Here's what you do if you have very basic resources. Here's what you do if you have maximal resources. That's a nice feature. And any guidelines always has this disclaimer. It says, it's not, don't use it like a robot. It's gotta be, you gotta use your judgment. And you have to consider what your resources are and what the circumstances are, and if there's any new dangerous findings that have been reported by a federal agency like the FDA. Okay. Last core piece, the 5 steps. This is the process of evidence-based practice. So this is a 5-step process. It's very specific, and this is really what they intend you to go through. First, they want you, when you see a patient or you see a social problem, they want you to ask the question you need an answer to, and we'll give some examples of those. Then step 2 is they want you to acquire the best available evidence, and step 3 is critically appraise it for its validity and how relevant it is to the problem. That, step 3, is where most training in evidence-based practice stops. The last 2, where you apply the evidence and where you figure out if it's working and course correct if it's not, that almost never is addressed, and that's where the work is needed. So I hope this is where you will pioneer in evidence-based practice. This model is more commonly shown in this form as this circle, and you see it going through. You start with ask, you acquire the evidence, appraise it, then apply and analyze and adjust. And you can see why all the emphasis on systematic reviews and guidelines. Because what they do is that they handle the first 3 for you. They ask the most common clinical questions. They acquire the evidence and appraise it. So if you're a busy clinician who is seeing patients in 10-minute intervals back to back to back, somebody has done this work for you. So you don't have to disappear into the library for a year after seeing every patient. Okay. This is a resource that, if you don't know it, I think you may find very valuable. Remember I mentioned the multidisciplinary group that I worked with to come up with the transdisciplinary evidence-based practice model? This is a website that we assembled. It's www.ebbp.org, stands for Evidence-Based Behavioral Practice, and it has all kinds of good stuff on it. It's free. It has 9 different online learning modules. All you need to do is to register, and everything is free. You can take pre- and post-tests to see what you learn. There's all this training. What we're going to do in the workshop tomorrow is actually to work through from 2 to 7 with some cases. This is, it's a really nice tutorial. We've just completed analyzing the effect of taking the modules on test scores, and everybody learns. So it actually works. Okay, critical appraisal. Here is something that is another core concept. The hierarchy of evidence is a core concept in evidence-based practice. And sometimes people object to this. So what I'm showing you here is what is known as the evidence pyramid. It's the evidence pyramid for a question about treatment. And what you'll see is that the stuff that's at the bottom that gets the lowest rating is expert opinion, your eminence-based practice. What's at the top, or what's pretty high up, is the randomized control trial because it minimizes bias. And at the top is systematic reviews because they pull together results from lots of clinical trials. So what do you not see in here? Qualitative research. So this is a thing that many people object to. But it's actually a misnomer. There is not just one evidence hierarchy. There are many. Because the best evidence depends on the question that you're asking. The vast majority of the work in systematic reviews and treatment guidelines has been about figuring out what treatments work. So the randomized controlled trial, double-blind, is the gold standard for that. It's the best research design to figure out if a treatment works. But there are other questions you might have, and other designs are better for those. So if you've got a patient with certain characteristics and you want to know how long they're going to live, you want to know what's their likely course, a cohort design is best for that. For causation, similarly. Cost effectiveness, different kind of design. And I would argue some things that I think are particularly important for you. To the extent that you're trying to apply treatments that were developed someplace else in this cultural context, it's really important to evaluate fit. And I would argue that for that, qualitative analysis is going to be your best way to go. Because you don't want to just go out and do a randomized controlled trial if people are going to say, huh? It's just, this thing doesn't make any sense. Okay. Apply. This is where things get really tricky and there's very little guidance. So I'm going to give you an example of how crazy things can get when you do apply. So this is actually a case that's in the EBPorg modules, the online modules, where this happens to be a woman who, and it's a fake case, so I'm not really telling you anything about this person. She became depressed after having a mammogram which detected breast cancer. And so there's a problem. She's depressed and not functioning very well. You do your evidence search and you find that there are a couple of different randomized controlled trial verified treatments for depression in this context. One of them is individual psychotherapy. Another is a couple of different kinds of moderated support groups, supportive expressive, and there's also a cognitive behavioral group. So you talk with the woman and you explain to her your treatment recommendations. The woman says, I don't want to do any of those. I just want to be around other people that have the same problem I do. I want to go, there's a group of my neighbors that have this problem. I just want to go work with them. So now here you are trying to apply evidence-based practice. And what this module does with you is it gives you the options for what you can say, and you choose one. And then you work through what are the consequences. So you might say, look, the evidence says the thing that's going to help you is individual therapy. So you could say that. Or you could say, look, lay support just without a moderator it's not evidence-based. There are these other kinds of groups that are evidence-based. You could say that. But to some extent, this is like the sort of talking down to her. So what actually winds up being the best option in this case is to say, okay, I'll help you find the different lay groups. Let's stay in contact. And what in fact happens is that she goes to the lay group. She finds that it's nice, but it's not as supportive as she needs. She comes back and continues the relationship and goes for an individual therapy. So this is a case where when you go to apply the evidence, sometimes you have to take an indirect route in order to preserve the quality of the relationship that will let you get the person into an evidence-based practice ultimately. So things get a little bit spooky here. Okay. Concluding here, you can see why this is an international movement. To do evidence-based practice, it really does take a village. It takes the people who are doing the primary research. It takes the people who are pulling it together as systematic reviewers. And the people who have the toughest role are the people who are trying to apply this evidence, who need to deal with all of these different components. So just to wrap up, I would suggest that you're very smart here in that I think you have the ability to avoid some of these artificial dichotomies that really have impeded the growth of evidence-based practice. This notion that the best science can't be useful, I think that was a mistake. The notion that there's a disconnect and opposition between scientific versus expert or empathic practice, that it's automatic that science-based practice disrespects either the clinician or the patient. I think that's just not necessary. I think these concepts of use-inspired basic research and evidence-based practice have been helpful in letting us translate research to practice. And that at this point, these concepts and methods of evidence-based practice have really been taken up by most health professions, so they give a good basis for interdisciplinary collaboration. And that at the policy level, health in all policies has become a basis and a model for collaboration across different sectors. Evidence-based practice is not just a metaphor. There are three core concepts, these three circles, the evidence hierarchy, and the five-step method. They really mean something. But a problem is that a lot of evidence-based practice training proceeds only through critical appraisal. So you know what the evidence says, but the question of how do you apply it, nobody wants to get messy with that one. But that's where we have real work to do on shared decision-making, negotiation, a lot of the things that you're going to tackle here. Evidence-based practice really is a team science, and it requires primary researchers, systematic reviewers, and clinicians or practitioners. This infrastructure that you get from systematic reviews and practice guidelines is critical. Given the sheer tsunami of incoming research, there's no way that anybody could do evidence-based practice if they had to live in the library trying to keep up with the 7,000 articles a day. And I think really the frontiers of interdisciplinary evidence-based practice are going to be how to optimize this collaboration, the shared decision-making among stakeholders, and what to do when you start out with your best evidence-based practice and you find out it's not working. How do you course correct, and how do you individualize that to the extent possible? So I always have to stop by thanking my funders and my team, without whom I would get nothing done. So thank you very much for your attention.